All right, guys, it is Thursday, and it's 11/12/2020. We are going to complete the medical gas therapy lecture today, talking about oxygen and O2 therapy, the different hazards and indications, and a couple of different devices that are used. And today we're going to get into the oxygen analyzers and the hyperbaric chamber. And then we will be completing that on up, okay? All right, so let's go back to the PowerPoint where we left off. Hyperbaric therapy. We know that the atmospheric pressure at sea level is 760 millimeters of mercury. That's the pressure of all of the gases in the atmosphere, okay? All the pressures of the gases in the atmosphere added up together equal one pressure of 760 millimeters of mercury. Whose law was that? Who remembers whose law that is? That all of the gases in the atmosphere equal one pressure.
Dalton's.
Dalton. That's Dalton's law, okay? And so now we know that at a pressure of 760 millimeters of mercury, oxygen in the atmosphere exerts 159 millimeters of mercury, right? And that's 21% of the atmosphere is oxygen. And you take 0.21 times 760, and that gives us a pressure of oxygen in the atmosphere of 159 millimeters of mercury. Now, when that gets into the body, we have to subtract CO2, we have to subtract water pressure, and all of that out of it, right? And we end up with an alveolar oxygen pressure of about 99 millimeters of mercury. Well, sometimes that 99 millimeters of mercury is not enough to accomplish supersaturation, right? We want to be completely saturated. So sometimes when patients have conditions like have to have a lot of blood transfusions or have been in burns, right? Have had a lot of edema. Sometimes we have to do what's called hyperbaric therapy, which we make the pressure around the patient become heavier, okay, stronger. And that is when you take into account more than one atmosphere. So at one atmosphere, the pressure is 760. At 2 atmospheres, the pressure will be what, 1520? And at 3 atmospheres, it's up to, let's see, 760 times 3, 2,280 millimeters of mercury is the atmospheric pressure. So if we are at 3 atmospheres, then what is the pressure of oxygen at that time? What is the pressure of oxygen at 3 atmospheres? 2280. How much? 478. So oxygen at 3 atmospheres is 478 millimeters of mercury. So that means it's going to help us do a whole lot more with the oxygen that we have, okay? If the patient is just on room air, but we take them down to 3 atmospheres, then that's going to put more oxygen in the alveoli. The pressure of oxygen becomes greater, and that way it is forced farther down the line of the body. So for instance, if I have gangrene or somebody who has diabetic necrosis in the limbs, we can put them in hyperbaric therapy and we'll force the oxygen down to the tissue level, okay? Because it's way more pressure. So before we get started, I want you to tell me, what is the alveolar air tension at 3 atmospheres if the patient is on room air? If your patient is on room air, what will be the alveolar oxygen tension at 3 atmospheres? I want you to work that out right quick. what will be the oxygen tension in the alveoli when the patient is down to 3 atmospheres? I'm going to work it out too. They're on room air. Don't forget to subtract the CO2 out of it. There you go. All right, so let's see. Ms. Thomas, what did you get?
I just found my calculator, so.
Still working on it. What you get, Ms. Scott? Ms. Scott, you're right. So, Kayla, you're not sure? Okay, it's the alveolar air equation, guys. So you do the alveolar air equation. So let's do it on the board. Alveolar air equation at 3 atmospheres. Patient is on room air. So let's see how much more power that oxygen has to do its job if we take them down to 3 atmospheres instead of just 1, right? We can make job of the oxygen much stronger at 3 atmospheres. So let's see, the P big A O2 at 3 atmos. Okay? And on room air. So that's P big A O2 equals 0.21 times P bar at 3 atmospheres is 2280, right? 2280 millimeters of mercury minus the water pressure, which is 47 millimeters of mercury, right? Then we have to keep on with the subtract CO2, okay? Now, when we got our answer, guys, we didn't take into effect the CO2 because the CO2 as well is going to be different at 3 atmospheres, okay? But we're not going to worry about that because we're just going to worry about the CO2 in the ABG, okay, which is the P little a O2. But do think about that. It would be a little different at 3 atmospheres, but we're going to just do it regular. If we got a ABG, the PaCO2 of normal, which would be 40 divided by 0.8, right? So now, 2280 minus 47 was 40. Hold on, because I had already did the multiplication. Okay, so 2280 minus 47 is 2233. 2233, okay, times 0.21 minus 40 divided by 0.8, guys, is 50. Right? You can see that good. But... right? And then 2233 times 0.21 is 468.9. So this is 468.9 minus 50. And that gives us a P big A O2 of 418.9 millimeters of mercury. Okay? So at 3 atmospheres, if I'm just on room air, look how much more oxygen power I have. Look how much more oxygen power I have. PaO2 at 3 atmospheres. 0.21 times 2280 minus 47 minus 40 over 0.8. And we do the multiplication, we come out to 418.9 millimeters of mercury. So that is a lot more pressure. Oxygen has a lot more pump, right? It has a lot more drive just because I brought it down a couple of atmospheres, all right? And so that's what we're going to be doing to our patients that need hyperbaric therapy, because if that 100 is not enough to get to that diseased, necrotic leg that you got, and you're trying your best not to get it amputated, right? Because when we don't have oxygen to a part of the body, that part of the body will die, okay? And so if the perfusion and the oxygen is not getting there, the nutrients and all of that, it's going to die. And if it dies, you're going to have to cut it off so that the infection or the gangrene does not kill the body, okay? And so now with hyperbaric therapy, we can force that oxygen down to those necrotic tissues to try to keep them from dying, okay? Try to keep us from having to cut that leg off. Or sometimes we have burn patients who have been burned to 3rd degree, and oxygen helps with healing, okay? A lot of times at the med, when I worked at the med, a lot of Dr. Hickerson, who was the burn doctor, he would have patients on oxygen that didn't need oxygen, okay? You're like, well, wait a minute, he's on oxygen, he's sat in 100%, he doesn't need oxygen. And so his rationale is because oxygen helps so much with healing, okay? So he wants his patient, all of his burn patients are on at least 2 liters per minute, okay? No matter if they need the oxygen or not, because that oxygen helps with the healing process. And so when you are burned down to the 3rd degree, we can put you in a hyperbaric chamber to help heal those tissues. When we graft pieces of skin from your leg or something to put on your face to try to make your appearance a little bit better, the oxygen in that room helps the healing process, the fusion process of those tissues, called a skin graft. It's better if the patient has a lot of oxygen on board. And regular oxygen might not be enough for the severely burnt patients or edema, swelling patients. So we put them down, down, down to 3 atmospheres and try to make that oxygen that is present work harder, okay? It has a better representation now. It goes from 99 millimeters of mercury in a PbAO2 to 418. That's a whole lot more pressure of oxygen, okay? And so it can do a lot more work. So let's look at the hyperbaric therapy and how it works. How it works. Okay, the definition of hyperbaric is therapeutic use of oxygen at pressures greater than 1 atmosphere. Pressures are usually expressed in multiples of atmospheric pressure, absolute. That's ATA. Atmospheric pressure absolute, okay, ATA. And so 1 atmoles or 1 ATA, same thing, is 760 millimeters of mercury. You already know that, okay? But what we can do is go farther than that to help different situations. So what are the physiological effects of putting somebody in hyperbaric therapy? Well, you decrease the size of trapped gas bubbles, okay, which is part of Boyle's law. It's used to treat decompression sickness. When somebody comes up from being really low, like a diver that goes really, really deep looking for gold or treasure or whatever, and he or she comes up too fast, the nitrogen in the blood starts to bubble, okay? You have air bubbles and trapped air bubbles because of the nitrogen. And so what we do is we can put them in a hyperbaric chamber that will bring their pressure back down to treat that, okay? And so we slowly bring them back to 1 ATA or 1 atmosphere, okay? So they're no longer that decompression sickness, okay? Decompression sickness. All right. Else, number 2, supersaturation of the plasma. Supersaturation of the plasma, the oxygen in the plasma, occurs due to increased partial pressure of oxygen, which is Henry's law. PaO2, P little a O2, that's in the artery, right? They can reach up to 1,500 millimeters of mercury. The level of the P little a O2, once you put them down in hyperbaric, we know that the P big AO2 can shoot up to about 418. But the P little AO2 can reach levels of 1,500 millimeters of mercury. That's called supersaturation. Supersaturation of the blood. Increases O2 transport to areas that are what? Poorly perfused. Okay? So that's that dying leg down there, or that toe that's about to fall off because it's dying, right? If we want to save it, we can supersaturate you in hopes that we can save that limb, okay? Another thing it does is generalize vasoconstriction, okay? So what that does is that treats edema and swelling, right? Because a lot of people have tissue and edema swelling, edema and tissue swelling and burns. When they get burned, the skin swells up, okay? And it becomes has edema, and sometimes it's so much edema that you can press down on the skin and water will come out. Okay, that's called pitting edema. You put down, your fingerprint just stays there. Okay, that's so much water, almost called third spacing. The water now has found another level of space to take up, and that can be bad, especially if it gets around the heart or the lungs and makes it harder to breathe. And so we can put somebody in hyperbaric that gives us vasoconstriction, which takes that swelling away. The same effect that we get with racemic epinephrine in the throat. When we have anaphylactic shock, you get stung by a whole bunch of bees and that throat starts swelling up, that's anaphylaxis, right? And we can give medicine called racemic epinephrine because it's an alpha stimulator, which you'll learn when you get to pharmacology. Alpha stimulator drugs will vasoconstrict and reduce the swelling in the throat so the child or the person can breathe, all right? But not only pharmacologically, but we can do it with the hyperbaric therapy. So it reduces edema and tissue swelling and burns, cerebral edema from when you have a head injury and that's the brain swells up, right? Hyperbaric therapy can bring that swelling of the brain down. And crush injuries, people who get crushed, like if you were working on a forklift or something and the forklift drops a whole pallet on you. That's a crush injury. You shattered your pelvis, right? Things like that or your leg is completely crushed or shattered. Hyperbaric therapy helps the healing of that, okay? It's very amazing, all right? And B says maintain oxygenation due to increased PaO2. Okay, that's obvious, okay? Let's see. Okay. Increased elimination of carbon monoxide due to high pressures of oxygen. Remember what we said? We said the hemoglobin loves carbon monoxide. How many times more? 200 times more. 200 times more. So how did I say we treat a carbon monoxide patient? Give them 100% oxygen. Give them as much oxygen as you can give them in hopes that the hemoglobin will shake off those 4 sites. It will shake off the carbon monoxide and pick up oxygen, okay? Well, you can do that and take some time, or you can put them in hyperbaric therapy, and now that the oxygen has so much more right, it'll do it so much faster. So let's look at it. The half-life of carboxy hemoglobin, because we said carboxy hemoglobin is normal at certain levels, right? You're going to have some carbon monoxide on your blood, all right? About 0.5% is normal, all right? Then we said, I think 10% comes after smoking, and 40 to 60% will kill you, right? All right? So the half-life of carboxy hemoglobin under hyperbaric oxygen at 3 atmospheres is 23 minutes. So if I have a patient, a firefighter, or a family member who has suffering from carbon monoxide poisoning, I can throw them in a hyperbaric chamber and the hemoglobin will shake off the carbon monoxide in 23 minutes. Okay? Now, that's in the hyperbaric chamber. Let's look and see if they're just breathing a non-rebreather. Remember the non-rebreather we talked about yesterday with the mask with the bag and the valves on it. The valves on the side and in the middle, where the patient is only breathing 100% oxygen. Okay? So if I don't put them in a hyperbaric chamber and I just pull them out the fire and sit them on the sidewalk and put a non-rebreather on him, how long will it take to shake it off? 80 minutes. 80 minutes. And that is on 100% oxygen out of the fire. Okay? I brought them out the fire, got them in the ambulance, put a non-rebreather on them, and in 80 minutes, the carbon monoxide will finally be shaken off of the hemoglobin and the patient will start to recover. Okay? 80 minutes. That's over an hour. All right? Well, what if I don't even do anything? What if I just pull them out of the fire and sit them on a curve and don't give them no oxygen? How long will it take then? 5 hours. So I can either pull the patient out of the fire, right? Get them out of the source of the carbon monoxide, sit them on the curve with nothing. And it will take 5 hours for the hemoglobin to shake off the carbon monoxide and pick up oxygen. Or I can put them in a hyperbaric chamber at 3 atmospheres and then they shake it off in 23 minutes. So you see the advantages of hyperbaric therapy, okay? It makes the oxygen that you do have that much stronger, okay? That much stronger. So make sure you know that. These different ones, 3 atmospheres in the hyperbaric chamber is 23 minutes. The half-life of it, if they're just breathing 100%, like I got them on a non-rebreather, but they're not in hyperbaric, just on a non-rebreather mask, it's going to be about 80 minutes. And if they're just breathing room air and not in hyperbaric, it's going to be about 5 hours, okay? And depending on how bad it was, they may die, okay? It may have been in there so long that them 5 hours will be too long, okay? Too long. And that's why you come in the hospital when you're in ER and you smell smoke when a patient get in there. You know what couches smell like when they burn. You know what a house fire smells like. I'm not sure everybody has smelled one before. It's got that certain smell. If you smell that on your patient, put them on a non-rebreather immediately. Don't just put them on nasal cannula or none of that. Put them on a non-rebreather because their oxygen saturation on their finger, it's going to say 100%. But it's 100% saturated with what? Carbon monoxide, not oxygen. So that can fool you, okay? Never treat the numbers, treat the patient, okay? Because that number up there will mislead you. Oh, he's sat in 100%. He smell like smoke and everything, but he got 100% sat. I'm going to put him on a little 2 liters or whatever, or nothing at all. He all right, okay? No, don't do that because he could be suffering from carbon monoxide, or he is suffering from carbon monoxide poisoning, and you could eventually cause more harm than helping him, okay? So you got to know that, yeah, he's sat in 100%, but he's sat in 100% saturation with carbon monoxide and not oxygen. What else does the hyperbaric chamber do? It helps the white blood cells fight harder, right? Not only do the red blood cells, which contain the hemoglobin, have a stronger right? But also the white blood cells or the leukocytes also have a little bit more power. It's like putting bulletproof vest on your white blood cells, right? Them your soldiers, right? When you put them in hyperbaric, now you have armed them with even more, okay? You gave them more weapons and you have put an armor suit on them, okay? And so the white blood cells have an increased ability to fight infection when they are exposed to hyperbaric oxygen, okay? Now, hyperbaric oxygen is lethal to anaerobic microorganisms. So if you are suffering from an anaerobic microorganism, that means it's a organism that thrives in what type of environment? An anaerobic microorganism is a microorganism that lives and thrives in what type of environment? No oxygen. That's how he lives. There's got to be no oxygen around. He thrives, But if I put you in hyperbaric, he can't live, because then you become aerobic, right? Aerobic means with oxygen, anaerobic without oxygen, right? And so the anaerobic microorganisms pop up in areas where there's no oxygen present, or very, very low oxygen present, right? And they're fighting and killing you, right? But if I increase the oxygen tension in my body, those microorganisms have no ability to fight, okay? They die. And so the white blood cells can come wipe them out real easy when you're in hyperbaric oxygen, okay? All right, so this is just a picture here, how to prepare for a hyperbaric chamber. Follow instructions for yawning and swallowing. You know, when we go up in the mountains or up in a plane, your ears pop because there's a decompression or a difference in there's a difference in pressure, right? When you oh shit, I forgot about that. It's a fire drill. I'm gonna pause the recording right here. All right, fire drill is over. We're back in the building. So I was talking about how to prepare for hyperbaric chamber. Of course, you're going to follow instructions about yawning. They're going to tell you about when you should yawn or not. Because when you go into a higher elevation or a lower elevation, your ears pop, right? Change your body, your brain, your middle eardrum will sense a difference in pressure. And so sometimes we have to yawn and pop to get our hearing back, stuff like that. Don't smoke, of course, because it supports combustion because there's oxygen in there. Avoid alcohol and carbonated beverages because carbonated beverages are more bubbles, okay? And then shower and avoid all perfumes or lotions because you just don't know, those scents may become stronger in hyperbaric therapy, but they want you to make sure you shower though. You don't want to be in there stinking, okay? Have it musty for the next person. All right. Now, another thing that it does is Neo-Vascularization. What does Neo mean? What does Neo mean?
Maybe.
New. It means, yeah, new. It means new. Neo means new. So new vascularization. Formation of new capillary beds in poorly perfused tissue. Not only does that oxygen get to the tissues that's there, but it makes new capillary beds. Little new capillary beds are formed in the presence of hyperbaric therapy. It's amazing, right? So those tissues that didn't have good perfusion start to make new little capillaries and new little blood vessels start to form in those areas, and blood reaches out to them, right? So if you had dead fingers or they were almost dead, then the hyperbaric therapy would then start to make new little capillaries in your fingers. And then as they form, the blood flows to them. And as the blood flows to them, so does the oxygen, so does the nutrients and all of that in life, okay? And bring that finger or that foot or whatever back to life. Very amazing, very amazing. It's helpful in treating radiation necrosis of bone tissue. Somebody who may have had cancer and had to have radiation, sometimes the radiation can destroy the bone tissue, okay? And so hyperbaric therapy will help that. Necrotizing fasciitis, which means it's like skin-eating disease. It's a disease that's eating and killing the skin itself. Necrotizing means killing, right? Necro means death. Gas gangrene. You ever heard of, we say you don't, if your leg get infected, you're gonna get gangrene. Okay, that's all that is. Gas gangrene. It treats that. And difficult to manage wounds. When somebody has a wound, a really big sacral wound or something like that, that's hard to heal, put them in hyperbaric because oxygen is healing. Okay, oxygen is healing. You got more oxygen there. You have new blood vessels being formed there to go and heal it, right? Heal the healing process. I wish you could look at it at like a high-speed camera, like just watch it for like a month and watch how the body heals itself in fast speed, right? And in hyperbaric chamber, it helps it manage or heal that wound a lot better. All right, so the general conditions that it benefits, like we always had a little word, food for thought. These are the general conditions about hyperbaric therapy. Accepted conditions that may benefit from hyperbaric oxygen therapy. HBOT. Gas gangrene, radiation necrosis, carbon monoxide poisoning, ischemic tissue transplants. That's when you take a piece of your butt cheek and put it on your face because you had a burn, okay? Necrotizing soft tissue infections, decompression sickness, also known as the bends, refractory anaerobic infections, okay? Refractory, meaning they don't respond, right? So you have those anaerobic infections that are not responding to regular oxygen. Let's put them in hyperbaric oxygen and see if we can kill it then, okay? Severe acute anemia or hemorrhage. That means somebody who's bleeding a lot, who has an internal bleed. Like when you're losing that blood, you're losing oxygen, you're losing hemoglobin. And so we put you in a hyperbaric chamber. The little bit of blood that you do have has more of ability to fight, have more of an ability to perfuse and to heal, okay? Crush injuries and enhanced healing of problematic wounds, okay? So it's kind of like, if you think of it in money, like the only way you can get something is if you have a whole big stack of money, right? And so when you no longer have that whole big stack of money, like, well, what am I gonna do? Well, I'm gonna give you this one little credit card, right? And this little credit card gonna have more power than all of that money you just had in your hand, right? So if the oxygen the regular oxygen that I'm using is not enough, let me put you in hyperbaric therapy, and now the little oxygen that you do have is way stronger than all of what you had when you were outside of it, okay? Now, what's the equipment? How do I use the hyperbaric therapy? What do I use for that? Well, you have two types of chambers. You have monoplace chambers and you have multiplace chambers, okay? The monoplace chamber is a small vessel that holds one patient. Mono means one. And it's usually pressurized with oxygen, okay? Now, because when you get in, you have to pressurize it, right? You don't you don't get in and it takes you underground, right? You get into the chamber and they start turning the vacuum on and pressurizing that room, okay, down to 3 atmospheres. And usually they use oxygen to do that if it's a single chamber, if it's just you getting in there, right? Because I'm only treating you. But the multiplace chamber has several patients in there, right? And it's usually pressurized with room air, okay? The reason is because if I'm not a patient and I am the therapist that's in there, I don't want to be pressurized with oxygen, right? I'm going down right with you, but I don't want to be, what if I smoke? What if I'm a smoker? What if I'm a COPDer, but I'm a respiratory therapist, right? I don't want to get in there and get pressurized with oxygen and you make me fall out and die, right? Because you make my oxygenation really, really high. You make my PaO2 1500 when I like it to be 60 or 70. You know what I'm saying? So you're going to hurt me like that. So the multiplace chambers allow workers to be in there that are not being susceptible to that oxygen pressure. We pressurize it with just room air, okay? And that way, so how does the oxygen get to the patient if you only pressurizing it in room air? Well, each patient will have a mask on or a hood on receiving their individual oxygen, okay? So if that person has a little hood on and they're getting 40% oxygen, well, once we turn them down to 3 atmospheres, that pressure of oxygen that they were getting is way more, right? But if I'm standing out beside you, I don't get that effect, okay? I'm down to the 3rd atmosphere with you because I'm in the chamber, but I'm not pressurized with oxygen. My saturations are not going super saturations, okay? They're going to go up a little bit because I am getting room air, right? I mean, I do breathe regular room air, so it is going to go down, up a little bit, but not like it will be for you if you have oxygen on. All right. So the patient breathes oxygen via a mask or a hood, and these chambers, these multiplace chambers, allow healthcare provider to be in the chamber with the patient. So here's an example. On the left, you see multiplace chambers. You got patients in here, and here goes the worker right here. This whole hyperbaric chamber is pressurized down to 3 atmospheres with room air, okay? But each patient has a hood on that's receiving oxygen, okay? And so the oxygen in their body is really, really high, right? And the oxygen in his body is just a little high, all right? Because he's not getting oxygen like they are, okay? So this is a nice, comfortable hyperbaric chamber. Looks like kind of like a submarine. A lot of them look like you're getting into a submarine, okay? See the windows are tatted in because you don't want to fall out. If it was regular window, it would suck in and crush because you so much pressure inside of there, all right? And on the right is a monoplace chamber. This is a hyperbaric chamber for a single patient, right? And this one would be pressurized with oxygen because you don't have to wear a mask because the oxygen is going to be inside the chamber, okay? So I'll slide you right in and shut the door, okay? You see they got a little flat screen TV where they can watch TV and be comfortable for wherever the therapy is. I think it's an hour or two or something like that, okay? Now, what are the contraindications or hazards of hyperbaric chamber? I always say too much of anything can hurt you. Okay? Too much of anything can be bad. So, what are the contraindications? Some of these patients I will not put in hyperbaric therapy. All right? There is an absolute contraindication, and then there's some relative contraindications. Okay? Absolute means I don't care what benefits you think you're going to have, this patient cannot go in, okay, no matter what. That's what absolute contraindication means. Other contraindications like, well, you shouldn't do it on this patient, but sometimes the benefit outweighs the bad, okay? So you might do it in certain instances, but I really wouldn't want to do this patient, but, you know, I might if I need to do this or that, okay? But absolute contraindication means I don't care what the benefit is, you cannot go. Okay. All right. So simply, let's make an example. A contraindication of getting in the swimming pool would be, you know, you just learned how to swim. You can swim a little bit, but you just learned. So I'm gonna watch you, right? I really don't want to just get you in there yet by yourself. But a person who has no arms, no legs is absolute. Don't put them in the pool. Okay. I mean, that's as easy as I can make it. Do not put the person with no arms and no legs in the pool, all right, because he's going to drown, okay? Simple as that. All right, so the absolute contraindication for hyperbaric therapy is a untreated pneumothorax that occurs during therapy or if they already got it. A pneumothorax is a hole in the what? The lungs. A hole in your lung is called a pneumothorax. A hole in the lung. So if somebody has a pneumothorax, I do not want to put them in hyperbaric chamber because I'm increasing the pressure and that's going to make it worse. Okay, that's going to make it worse. It's going to collapse the lungs. It's going to be really bad, kill you. Okay, absolute contraindication of the hyperbaric therapy. When you get that test question, the absolute contraindication is an untreated pneumothorax. Okay, another contraindication that you might do it, but you know, is a patient with a URI. It may, I think that's upper respiratory infection. They have an upper respiratory infection. It may be difficult to clear their ears during therapy. And I think it's something else. I'll find out exactly what that is. It's something got to do with the ears. But just know, patient with a URI, because it may be difficult to clear their ears during therapy, right? Remember how you have to pop your ears or swallow whatever, and they, with this condition, may not can do that, and it may just build up pressure more and more and hurt them, right? May be necessary to postpone the therapy until that infection has resolved. So it might be upper respiratory infection. So yeah, you might need to wait till that infection is over with before you do the therapy, okay? Might resolve that first with some antibiotics first, and then put them in there, okay? Number 3, patients with air trapping. Patients with air trapping. So air trapping is when I breathe in and I breathe out, but before I can get it all out, I breathe in again, right? That's leaving air still in there, okay? That's called air trapping. Slower decompression rate may assist a patient with eliminating gas as it expands due to decreased pressure or decompression, okay? It expands. So you don't want to have a whole bunch of air in there and then it expands. It's going to be sharp pains in the chest. You know how gas can be, get a sharp pain. It's like, ooh, I got gas. You think you're getting a heart attack, right? Well, if you have that gas in there and you're doing hyperbaric therapy, it can expand that gas even more, okay? Some more hazards. Some patients may be unable to equalize pressure in their middle ear. So they may have to get tubes. You ever heard somebody say, I got tubes in my ears? Or some babies or kids had to have tubes put in their ears because they have middle ear issues, okay? And sometimes they might have to place tympanomy tubes in their ears bilaterally before therapy. So they put the tubes in there, then put them in the therapy so that the pressure doesn't cause a problem, okay? Because they don't know how to pop them by yarning, okay? And so sometimes we have to put those tubes in their ears to equalize the pressure and then put them into hyperbaric therapy, okay? Because that's something that, you know, they got that problem, but they also have a dead leg, right? So I want to fix them. I mean, popping my ears is an issue, might be a little uncomfortable, but I need this leg to heal, okay? So I will put them on in there, but I need to watch out for it, okay? And then finally, patients with what? For chronic hypercarbia. Who is that? What patients is that?
COPD patients.
COPD patients who always have high CO2, okay? So somebody who has high CO2, you may remove their what? Hypoxic drive. Because people who have chronic hypercarbia do not respond to the central chemoreceptors anymore. They only respond to the peripheral chemoreceptors, which respond to hypoxemia. So you always want them to be a little bit hypoxic. If you put them in hyperbaric therapy, they will not be hypoxic. I guarantee it, okay? Because you are super saturating their hemoglobin, okay? So you got to be careful with them because you might knock out their hypoxic drive, right? This causes respiratory depression, which will lead to accumulation of too much CO2. Because when you knock out the hypoxic drive, they start breathing slower and slower. And if they're breathing slow, they're building up more and more CO2. And that's called respiratory failure, okay? So I don't know why that's not an absolute, but I guess because it depends on how long you're going to do it with them. Because it doesn't knock out that hypoxic drive within the first 30 minutes or so. You know what I'm saying? It's like, it takes time for that to happen, okay? It takes time for that O2-induced hypoventilation to take place, all right? Usually probably about 24 hours or so, right? You can start knocking out their hypoxic drive like that. Because we don't forget, it don't matter what's going on with your patient or what their history is. If they are in an emergency situation, you can put them on 100%. 100% has not been shown to hurt nobody within 24 hours, okay? Even the COPD patient, okay? All right, this is an example of the tubes in your ears when they go in and insert little tubes in your ears. And they will take them in and remove them. It look like that will be painful, but things people go through to be healed. All right, now we're on the oxygen analyzer, which is the last part of this lecture. Oxygen analyzers. Oxygen analyzers are little devices that are used to measure the measure the FiO2 of the device. If I have a device that is blowing, right? If I have my device here, and again, I have this one here, which is the Gen, which does not have the Venturi on it. This one here, this little nebulizer here is the Gen nebulizer. It doesn't have a Venturi, so I don't know how much oxygen is coming out. Remember, it has the secondary one that I will plug up to the airflow meter and bleed the air in to try to bleed the FiO2 down, okay? But how will I know what the FiO2 is flowing out of this tubing, right? So when I have this tube and I have to stick an oxygen analyzer in the stream, I just put it in the stream of the oxygen flow, and it will start to give me some percentages. It'll tell me how much FiO2 is coming out of this tubing, okay? So that's what an oxygen analyzer is for. And there's several kinds of oxygen analyzers that we use, okay? So that will be the reason I will use an oxygen analyzer to analyze the oxygen that the patient is getting if I don't have the Venturi gate there to tell me how much they're getting, okay? All right, so to analyze high flow systems, I don't use them on low flow systems. We use oxygen analyzers on our high flow systems. Low flow cannot be analyzed, okay? Low flow systems can't be analyzed. You got to use them on high flow systems. Patients may not receive FiO2 analyzed if the flow is inadequate, okay? Is used in measuring the FiO2 during mechanical ventilation. Now, the machine or the ventilator itself has a built-in analyzer. Okay, so I can set a FiO2, but it's also a little number there that's telling you what is being analyzed. So if I got them on 45%, they may actually be getting 46 or 43, depending on whatever, okay? Some of them have that, some of them don't have that. Nah, that little 1 or 2% ain't. All right, this is what one looks like here. This is a picture of an oxygen analyzer, okay? You have the percentage right here. Look at this. This is the probe here. And this probe is sitting out in room air. So what should it read right here? 21 or 20.9%, right? So this reading room air. When I stick this analyzer in the stream of a pure oxygen source, like a tank, it should read, no, not the pressure, this is percentages here. 21% in the room air. And if I stick it right into the flow of 100% oxygen, it should read what? 100%. And that's how you calibrate it, okay? When I break it out for the day, I have to calibrate the oxygen analyzer at least once per shift, okay? So when I bring it out, I need to calibrate it first, all right? So I will calibrate it to the oxygen, to room air, and to 100%. Because if I put it in 100% and it's reading 93, I have to adjust it up to 100%. If I take it out and put it in room air and it's reading 18 or reading 23 or something like that, I just adjust it till it gets to 21, okay? That's how you calibrate. So you hit the calibrate button, put it in 100% and go up and down to 100%, and put it in room air and go up and down till you get to room air. And then hit the calibrate button again, now it's calibrated, okay? So whenever I put it anywhere, it's gonna read more accurate, okay? But you have to calibrate it first, all right? It's once a shift, okay? And then, but there's also times to calibrate it when I'm trying to calibrate a specific FiO2. And we're gonna learn that in a minute. If Miss Rose was on shift and you're coming on shift, Miss Cummings is coming on shift, like you work at night, she's coming in day, and you said, Mr. Johnson, he on 40% aerosol tray collar with the tandem, right? Which so doesn't have the Venturi, so you're not sure. Well, you would go in there and analyze it yourself to make sure, because she could have just said anything, right? She could have said what the last person told her. Nobody really has checked, okay? So to be accurate, you would go in and check it. You would put the analyzer in there and check the oxygen and notate or chart that it is on 40%. Mr. Johnson's oxygenation was calibrated at 40% FiO2. Okay, so that's done. Okay, it's charted. All right. But there's a way to do that. If you want to learn that, if it's 60% or less, or if it's 60% or higher that you think it is, you have a way that you have to calibrate it. Okay, a special way. We're gonna learn that in a minute. So this is the calibrator here. I mean, this is the oxygen analyzer. See this button right here, say CAL? This is the calibration button, up and down. See, I can calibrate it. If it's in room air and that's showing 23%, that's too much. That's too high. I need to push this down button, right, down to 21. Okay, and the same thing with 100%. All right. So this is one of them. This is one of the newer ones here. All right, you got some types. You have to know the types. You don't have to know the intricate workings of each one, because there are some incredible things that they do. It's like all that's going on inside of that dang machine. Yes, it is. But you don't have to know all of that. You just have to know some basic principles of it. You have the paramagnetic, also known as the physical analyzer. That's the first type. Paramagnetic, also known as physical analyzer. It says it uses the Pauling principle of paramagnetism. All right. Now, what happens inside of the paramagnetic or physical analyzer that's so amazing? The analyzer consists of two magnets in a hollow dumbbell field with nitrogen between them. The dumbbell is suspended by a quartz fiber with a mirror attached to it. Oxygen is attracted to that magnetic field, and its molecules will align themselves with the north-south magnetic poles. The dumbbell is displaced by the oxygen and is made to rotate. So the oxygen being magnetic field makes that dumbbell start to turn, okay? The mirror attached to that dumbbell indicates the degree of rotation by reflecting light into a special scale. This scale indicates the partial pressure and percentage of the oxygen in the sample gas. Amazing. That's amazing that it does all that inside. There's a little string hanging, a mirror, magnetic field, and the little mirror is turning, and the degree of turning tells you the percentage, and all that comes up on the screen, right? And that's all you see is the number, right? But all that's going on inside of the analyzer. Now, you don't have to know all of that. What you need to know about the paramagnetic or physical analyzer is this. Okay. It measures the partial pressure of gas. Okay. The paramagnetic oxygen analyzer measures the partial pressure of the gas. So when you look at that one, it's going to tell you the partial pressure, not the percentage. Okay. The paramagnetic analyzer will show you the partial pressure. It's going to be in millimeters of mercury, not percentage. Okay. There's other ones that show percentage, so you need to know the difference. The paramagnetic analyzer measures the partial pressure of gas. Okay. It also, the gas must be dry because water vapor will alter the magnetic field. Okay. So the gas that you analyze with the paramagnetic analyzer has to be dry. Okay. And so there's some little crystals in there that dry the gas, and they're called blue silica gels. The blue silica gels dry the gas, make it dry so that the analyzer can work, okay? And that measures the partial pressure of the gas. So those are the things you need to know about the paramagnetic analyzer, okay? You need to know that the gas that goes into that must be dry. And to dry it, it uses blue silica gel crystals to dry the gas, okay? And that analyzer will measure the partial pressure of gas. Now, the blue silica gels are the same little things that you have in your new shoes. When you buy a box of new shoes, they got them little pack that says, do not eat. That's blue silica gels, crystals. They dry the gas. They dry the air in it so the shoes don't mildew in transport. So they could be on the boat, you know, when they're coming over from wherever they made, and they could be kind of soggy or mildewy, all right? So they put those crystals down in there, those little packs that say do not eat, to keep it dry. The box will be nice and dry and fresh when it gets to you, okay? Those are blue silica gels, okay? Blue silica gel crystals dry the gas, all right? And it measures partial pressure. And that says the percent O2 scale must be recalibrated with changes in altitude. Don't worry about that. An example of the paramagnetic is the Beckham D2. Now look at this. It's an old school. Beckham D2. This is a paramagnetic analyzer here. Old school. It measures the partial pressure of the gas. All right. Number two, the second type of analyzer is the electrical analyzer. The electrical analyzer is pretty interesting as well. It uses the principle of thermoconductivity. What happens? A gas of greater mass and density has a better ability to conduct heat. Okay? So think about it. Which one is more dense, oxygen or helium? No.
Helium.
Helium is less dense. That's why it floats. I said, which one is more dense, oxygen or helium? Oxygen is more dense than helium. That's why helium floats. Okay? If I fill up a balloon with helium, the density is less. That's why it floats. Okay? That's why some people don't believe in gravity. Okay? Some people believe that there's no gravity. It's simply an issue of density. Okay? If something is more dense, it will fall. If something is less dense, it will float. Okay? If I take a steel ball and put it in a cup of water, that ball gonna drop straight to the bottom of the cup, right? But if I take that and then you say, well, that's gravity, right? But if you think about it, if I take that same cup and fill it with liquid mercury that's in a thermometer, and I put a steel ball on top of it, it's going to float. Well, where's the gravity? Why is it not dropping to the bottom of the mercury? Because the mercury is more dense than a steel ball. Okay? And so since the steel ball is less dense, it floats. All right? But it's more dense than the air, so it ain't gonna float in the air because the steel ball is more dense than the air. But it's less dense than mercury, so it will float in a liquid mercury cup. Okay? So that's what a lot of people say, well, where is the gravity? There's no such thing as gravity, it's only density. And those are your flat earthers that people think the earth is flat, and there's different reasons to that too. It's very interesting. Very interesting. All right, but you think, well, what damn, that is true. It does float on mercury. That makes sense. Where is the gravity? How come it's not going through, right? The butterfly does not fall to the ground because it's less dense than things around it, okay? But anyway, I digress. The electrical analyzer uses the principle of thermoconductivity. So the thing is saying a gas of greater mass and density has a better ability to conduct heat. All right. It uses special circuit known as a Wheatstone bridge. Underline that. The Wheatstone bridge is a very high name you'll probably see on a test question. A Wheatstone bridge is an example of an electrical analyzer, right? It uses a circuit known as the Wheatstone bridge to detect small changes of resistance. 2 chambers with electrical wires passing through each one. One for reference and one for measuring change in resistance. The cooling of the wire decreases resistance, which allows for increased electrical current flow. All this stuff going on. Oxygen is more dense than nitrogen. Okay? And so remember that nitrogen takes up 78% of the ambient air. Okay? But due to the increased density of oxygen, when more is in the sampling chamber, the wire is cooled the wire is cooled more, and so more current passes through the wire. So that's how it's distinguishing between nitrogen and oxygen, because oxygen is more dense and it can create more heat. And when there's more heat created, something's gonna make it cool. Okay? And so that's when it says, oh, that's oxygen, and that must be nitrogen inside of the analyzer, okay? By electrical principles, all right? By electrical principles. So due to the increased density of oxygen, when more is in the sampling chamber, the wire is cooled more, and so more current will pass through that wire. Here's the kicker. Electrical analyzers measure actual percentage and not partial pressure, okay? The electrical analyzer measures the percentage of oxygen and not the partial pressure. Okay? Are you on the PowerPoint? I'm on. You don't see the PowerPoint? Mm-hmm. Okay, because this I got it highlighted right here. This is what I'm talking about. What's really important. It measures actual percentage and not the partial pressure. So the paramagnetic measures what? Partial pressure. But the electrical analyzer measures what? The actual percentage. Good. The paramagnetic gas must be what? Dry. And we use what to dry it? Blue silica gels. Okay, good. That's what you need to know. All right. The electrical one uses principles of electricity, right? And it measures the actual percentage and not the partial pressure. Okay. It cannot be used within a flammable environment, of course. All right, still continue, electrical continue. Accurate only in oxygen, nitrogen mixtures, all right? And that's what most of the atmosphere is oxygen and what? Nitrogen. So that's what they're saying. It's accurate. But when you start trying to see how much oxygen is a sample of just pure argon, and then you got some oxygen there and you're trying to sample, it ain't gonna be really accurate. It's only accurate with regular, right? Ambient air, which is oxygen and nitrogen. That's the two biggest things. The rest of the stuff is very small. Like CO2 is 0.03, right? And stuff like that, 0.07 for argon or something like that. It's real small. The main two things is nitrogen and oxygen, okay? Now, the gas must be saturated with water vapor in the electrical, because water is a what for electricity? No. I'm saying when you think about electrical stuff, water is a good conductor, right? So you don't want me standing in the pool of water and messing with no electrical cord, right? So the more vapor is water vapor, the better the electrical pop, right? It has more conductivity. And so they want you to make sure the gas must be saturated with water vapor to do a good electrical reading, okay? Just like your heart works better when you have enough electrolytes on board, okay? If you don't have the proper electrolytes, the snap between the AV and the SA nodes is not there, right? It's not right on pop, right? It doesn't do that unless you have your electrolytes, right? Inside of your cell, you got to have potassium inside, and what's on the outside? Sodium. And when the sodium come in, what happens? No. When the sodium comes into a potassium-rich cell, what happens?
It constricts, right?
Contract. Depolarization. Depolarization, aka squeeze, aka systole, right? So we gotta have that. If I got potassium but don't have enough sodium, my squeeze is not gonna be right. That's got to be there, right? If I don't have potassium in my blood, then I don't have the conductivity. I don't have the contractility. You got to have good potassium. You got to have the good sodium. You got to have good magnesium, good chloride, right? You got to have all of those electrolytes for the heart to do what it's supposed to do. And so when you think about it on electrical grounds, water is an excellent conductor of electricity. So when you put a gas sample through an electrical analyzer, it's better if it's moistened with water, okay? And how do I make it wet? It uses pink silica gel crystals to saturate the gas. So if I want the gas to be moist, I use pink silica gel crystals, okay? Pink silica gel crystals will moisten the sample gas. And those crystals are already inside of the analyzer. So once you put the analyzer in the stream of oxygen, as it comes in, it's going to moisten before it gets to the electrical stuff, okay? So you can think about whatever you like. I think blue as air, right? Blue is air. So it dries things, right? So blue silica gel dries the gas, and pink is moisture. So if you think about somebody's lips, or moist lips, or pink, right?
Pink lemonade,
Oh, okay, well, pink lemonade, that'd be moist, all right? That'd be something moist, okay? The inside of your eyelids are pink, right? And they're moisture, okay? Or wet. All right. Examples of the electrical analyzer would be the mirror and the OEM. The mirror or the OEM. And they measure the percentage. Look at this mirror. This is old school. When I put the sample line, this little meter is going to read how much. Why is this green right here? No. I'm talking about this little, beside this number right here. Why is that little spot right there green? Nothing else has it.
That's where
Room air.
Room air. Good. So it's just letting you know that's room air. And then it will just go up to wherever it reads, okay? Old school. This is a little bit newer here. It fits in the palm of your hand, okay? All right, the next one. This is the electrochemical analyzer. So you have the paramagnetic, then you have the electrical, now you have the electrochemical analyzer. This is the third type of oxygen analyzer, is the electrochemical analyzer. Electrochemical. Now, the electrochemical has two types, galvanic and polographic. The electrochemical has two types, galvanic and polographic. All right? Hold on, let me. And they measure the partial pressure as well. okay? The electrochemical analyzers measure the partial pressure of oxygen, okay? Partial pressure. It's on a little bit further, but you want to write it down if you want to. I just want to go ahead and get those things that distinguish them. So the paramagnetic measures what? The first type, partial pressure. All right. Then the second type is the electrical analyzer, right? The electrical analyzer measures the what? Percentage. And that gas needs to be what? Moist. The paramagnetic, which is the first time gas, needs to be dry. Okay, good. Now the third type is the electrochemical analyzer, and they have two types, the galvanic and polographic. And both of those measure the partial pressure, okay? Both of those measure partial pressure of oxygen. Okay, now let's look and see how they work. The electrochemical analyzers use a chemical reaction involving oxygen to produce a current, which is what is used to indicate the percentage of the sampled gas. Okay, then the two types are the galvanic and polographic. The galvanic oxygen analyzer, composed of two electrodes immersed in potassium hydroxide, contained within a capsule with an opening covered by a polypropylene membrane that is permeable to oxygen. At the anode lead, the hydroxide compound is oxidized in the presence of oxygen. This releases electrons, developing a current, okay? Now, at the gold cathode end, oxygen is reduced to form OH ions, thus consuming the electrons. The current is measured from anode to cathode. The greater the partial pressure of oxygen, the greater the measured current. The measured current is used to indicate the percentage of oxygen. Okay, it's not done yet. The analyzer measures the partial pressure of oxygen. See, the measured current is used to indicate that percentage, but the analyzer measures the partial pressure of oxygen. Okay? It must be calibrated at varying altitudes and barometric pressures. Okay? So if you live in Memphis, it'd be calibrated to this pressure. If you lived in Denver, which is higher, you'd have to calibrate it there. Okay? It just makes a little difference. Okay? Makes a difference. And that's the galvanic. Now let's talk about the polographic. Polographic is also known as the Clark Electrode. The Clark Electrode. It's composed of two electrodes immersed in a potassium chloride contained within a capsule with an opening covered by a polypropylene membrane that is permeable to oxygen, just like the other one. At the silver anode, the potassium is oxidized in the presence of oxygen. This releases electrons, developing a current. At the platinum cathode, oxygen is reduced to form OH ions, thus consuming the electrons. The current is measured from anode to cathode. The greater the partial pressure of oxygen, the greater the measured current. The measured current is used to indicate the percentage of oxygen, but the analyzer measures the what? Partial pressure of oxygen. So the only thing different between the two is one is gold and silver, and the other one is platinum and silver. Okay, number 8, must be calibrated, of course, at varying altitudes, just like the other one, and has a battery to improve response time. Example will be the Instrumental Laboratories, Ohio. Okay, so all you need to know about the electrochemical analyzer is that it has two types, the galvanic and polographic, right? But both of them measure the actual partial pressure of oxygen. Excuse me. And the last one is straight up chemical analyzer. The last one is the chemical analyzer. The chemical analyzer utilizes direct subtraction of gases. A mixed gas sample is admitted into the sample chamber. Each gas in the mixture is removed and separated, and the weight change is equal to the percentage of gas in the mixture. And this is the one that is used in laboratories. You'll never see this on the floor. The chemical analyzer is used in the high-tech laboratories, okay? It takes all of the gases that you put in it, and it separates them, right? And as the gas mixture, each one is removed, the weight is changed. And the weight change is equal to the percentage of each gas in the mixture. So it's kind of like Dalton, right? If you think about the chemical analyzer, it kind of uses the principle of Dalton, all right? It kind of uses Dalton's principles. All right, so that's what you need to know about that one. Very, very little. You're not going to see that much. It's very expensive. This is a high dollar analyzer here. All right, so that's the 4 types of analyzers. The first type is the paramagnetic analyzer, which uses the dumbbell and the mirror and all of that, right? But it measures what? The partial pressure, and the gas in that one must be dry. Then you have the electrical analyzer, right? Which uses the electrical current through tubes and all of that. But that one measures the percentage of oxygen, and a gas in that one must be moist. We moisten gas with the pink silica gel crystals that are already inside of there, and we dry gas with the blue silica gel crystals that's already in that one. Then we have the electrochemical analyzer, which has 2 types, galvanic and polographic. Polographic, also known as Clark. Okay, also known as the Clark Electrode, the Clark. And it measures both of them measure the partial pressure of the oxygen. And then finally, we have the chemical analyzers, which just does almost like the Dalton principle, okay? The one that's used strictly in laboratories, okay? Right. Not really. It changes, kind of like the percentage. Each weight is a percentage of each gas in the mixture, but it's used in laboratories. You're not going to see much of that one at all. Okay, I don't see much of that one at all. Now, we're going to take a break, and then we're going to come back to calibration, because calibration can be tricky if you're not paying attention to it. You got to really catch what I'm saying when we calibrate the analyzer. So it is 9:26. Come back at 9:40. Come back at 9:40, and we will continue on with calibration of analyzers. Pause here. All right, here we go, guys. We'll continue on. Y'all don't need no miracle for tomorrow. Y'all. This ain't even that, y'all. This just read and look at the lectures. You're gonna be fine. You're gonna be fine. And then we got lab tomorrow and test. So we're gonna lab and all that before we take the exam. So as we labbing and all of that, you're looking at the stuff, you're gonna do it, then we'll sit down and take the test. So I mean, it's like a whole nother little part of review before the test. You're gonna be fine. 20 questions, not a big deal.
One question, everything you don't know else.
But you should though. You should. It's not that hard. You can do it. All right. Calibration of these analyzers. The analyzer should be calibrated to room air and then to 100%. That's the first calibrate. Okay. When I pull the calibrator out the box for the first time, or for the first time in a shift or whatever, I need to calibrate it to 21% first, right? So I take the calibrator, hold it up into room air, and make sure it says 21. And then I will hold it under 100% stream, right? So just turn on one of the oxygen flow meters and hold it under there, okay? And it should read 100, and I'll fix it to where it says 100. If it says 93, 95, then I push the up arrow until it goes to 100, okay? So that's that. All right, so when I initially calibrate it, I calibrate to room air, then what? 100%. Simple. All right, now, these 2 and 3 are important. If you tell me that Mr. Johnson is on 30% or anything less than 60%, and I want to go check for myself, then I need to calibrate my my analyzer first before I test it, okay? If that's the case, if I am measuring a value less than 60%, because you told me he on 40% or 30% or whatever, if I'm going to measure him, I need to calibrate to 21% last. So I calibrate to 100% and then 21%, and then I test him, okay? Calibrating is 2 things. You got to calibrate to room air and 100%. When I first get it out the box, I have to calibrate it 21% and then calibrate it to 100%. That's the first thing, okay? But if I'm getting ready to come behind you and test a patient, then before I test his stream of gas, I have to calibrate my analyzer, okay? And if you tell me it's anything less than 60%, whatever he might be on, if it's less than 60, then I calibrate to 21% last, all right? So I'm going to calibrate to 100%, then to 21%. Then I can test him, okay? If I'm measuring a value greater than 60%, then I calibrate to 100% last, okay? So if you tell me I got Mr. Johnson on, he's doing good, he's watching TV, he's on 78% aerosol Tracheal, okay? And I don't believe you, and I want to test for myself to see what he's actually on, and you telling me it's something greater than 60, okay? Well, then I'm going to pull out my analyzer, and I'm going to calibrate it to 100% last. So I'm going to calibrate to 21%, then 100%, then I'll put it on the patient, okay? Huh?
You say if it's
Greater than 60%.
Yes.
Calibrate to 100% last. So I will calibrate to 21%, calibrate to 100%, right? Then I go see what he on. Because I'm not calibrating when I put it on him. I'm testing. I'm analyzing when I get to him. Only time I calibrate is you only calibrate 2 ways. Calibrate to 100% or room air. But it matters which one you do first or last, depending on what you think you about to measure, okay? When I pull it out the box, I calibrate to 21% and then 100%. Put it up, okay? But then when I'm ready to analyze a specific patient, if he is on less than 60%, then I'm going to calibrate to the 21% last, okay? I'm going to do 100% and then 21%, and then I will put it on him to see what he is, okay? If he is on greater than 60%, then I'm going to calibrate to 100% last, okay? So I will go in there and I will take, if you tell me he on 75% FiO2, then I'm going to take out my analyzer and I'm going to calibrate it to 21% first, and then I'm going to calibrate it to 100%, and then I'm going to put it in the stream of the patient, okay? So for instance, Ms. Rose, if I told you Mr. Johnson is on 50%, then what do you analyze? What are you calibrating your analyzer to last? 21. It's less than 60, so you calibrate to 21 last. You do 100, then you do 21, then you put it on him. Simple, okay? If it's greater than 60%, Ms. Cummings, what am I going to calibrate to last? 100. So if you tell me, if I tell you Mr. Johnson is on 75% FiO2, you're going to pull out your analyzer and calibrate to 21% and then 100%, because you do 100% last when they're greater than 60%. Okay? That's all. That's as tricky as it gets. Okay? That's it. That is it. But you have to remember that because it's going to give you a false reading if you don't. Okay? It could give you a false reading. There's other reasons why you might get false readings on an analyzer. But also, how often should I calibrate the machine? Once per shift. And that's the number one part, right? Because I might not never use it. But once per shift, it needs to be calibrated to make sure it's still within range, okay? And the regular way to calibrate, like fresh out the box, is what? And then 100, and then put it up. If I use it, I use it. If I don't, I don't, okay? But the next shift, if it never was used, so what? I still want to do 21, then 100, put it up. Next shift, 21 to 100, put it up. But within that, if I do have to use it, then I need to make sure I do it properly, okay? to a specific patient, then if it's less than 60%, if you're telling me that he's on less than 60%, then I'm gonna calibrate to 21% last, okay? I'll do 100% first, 21% last, okay? If I think that he's on greater than 60%, then I'm gonna calibrate to 100% last. I'm gonna do 21%, and then I'm gonna do 100% last, okay? That is hard as that gets, all right? That's it. But I need to do it once per shift, okay? Make sure I do it once per shift. Now, what are some possible sources of error? Weak batteries, torn or wet leaky membranes, if the patient is on positive pressure or at a high altitude. This will be a multiple question. What all are sources of error in an analyzer? All of these except, or something like that, right? These are the 4 things that give you errors. Weak batteries, torn or wet leaky membranes, right? Positive pressure, if the person is on PEEP, right? Positive end expiratory pressure is PEEP, which is positive pressure. If they're on positive pressure, it could give you an error. Or altitude, they're in Denver or something like that. You take that same analyzer and go up to the Kilimanjaro mountains, it's gonna be different, okay? Because it's a different altitude.
What's positive pressure?
Positive pressure is when I'm forcing air into your lungs. You haven't gotten to that yet. But just know, if they're on positive pressure, like a CPAP machine, IPPB, anything like that that's giving positive, forcing air into you, it could be different, okay? It could give you an error. And that is it. That is it. So it's not that hard. Not that hard. So what? Let me go to the notes and see if we got something that's not on here. But what'd you say?
FPO2 monitor.
What about it? On your notes? Oh, that's probably using a pulse ox machine. Is that what it's talking about? Pulse oximetry? Okay, let me see if I can find that. That's something I think they added. Which ain't got nothing. All right. Oh, okay. Let me do this part, because the next part under that is just the lab stuff. Don't worry about that. That's not notes. That's they added that for lab. But let me share my screen with this little bit right here, which is where'd it go? All right. Yeah. Non-invasive O2 monitor. Now this is just the pulse ox that you have, right? The pulse ox that you guys were given that goes on your finger. That's non-invasive SpO2 monitoring, the saturation of oxygen. Okay. That is how much oxygen percentage is there, right? That's just the same thing as when you put it on your finger, you read it. It's non-invasive because I don't have to stick you for an ABG to get the PaO2, right? I just stick it on your finger, a little sticker on your finger, and it tells me your oxygen, right? Same thing you have in your pocket right now. It's called a pulse oximeter. It measures the saturation of the hemoglobin in arterial blood, but don't forget, it's not always oxygen. It could be what? Carbon monoxide, okay? And that simply talks about it uses a red and infrared light to detect the changes in color of blood caused by the binding of the hemoglobin. Sites used are the fingers, toes, and earlobes. Factors that affect accuracy will be moving around, sensor alignment, dysfunctional hemoglobin like carboxy hemoglobin, low perfusion. What if you don't have good blood flow to your fingers, right? That could cause a different ambient light, or skin pigmentation, or nail polish. If you got the overlays and all that, and they're gonna be able to read through all of that. Okay, that's all it's talking about. The transcutaneous is a little sticker I can put on your skin to tell me the oxygen it says provide continuous monitor of SpO2, transcutaneous, that means on through the skin. Okay, that means through the skin. O2 molecules diffuse through the skin and through the membrane of the sensor. The skin is heated to 42 degrees Celsius and to facilitate that diffusion. Makes it a little hotter so it diffuses easier, okay? Of course, you have to change that site often because you're heating it, all right? Placed on a flat surface of the chest and the abdomen, used mostly in little infants, okay? Because their little fingers be so small, right? So we put a little sticker on their chest or their stomach. And it's used to assess the blood flow changes also in the hyperbaric therapy. But that's transcutaneous monitoring. That's not on the exam, but that's good to know, though. It's good to know because we're talking about oxygen, analyzing oxygen, right? And so we analyze the oxygen, but we also can analyze the oxygen inside your blood by using a machine as well, which is the pulse ox, right? I can see how much oxygen is really in your system by using the little pulse ox machine, either one on your finger, toes, or your earlobe, or the one that's a little patch that goes on the baby's chest or stomach, okay? The rest of this down here is, I don't know if you got this. You got this too? Okay, yeah. This is for my lab, okay? This is how we set up the lab. All right, so that's this right here, guys. It's non-invasive monitoring, but that's it. That's the end of the lecture, okay? That's the end of the lecture. So let's do some work to make sure we got it now, okay? So, all right. Let's look at I don't know if you got this for your homework or not. All right, so work on this right here, guys. Let's work on this. This is a oxygen therapy, low flow and high flow systems quiz. Okay, it's not for a grade, but I want you to work on these, and then we can work on them. Then we can go over them. Do 1 through 5.
I don't see it.
Oh, I'm sorry. I'm sorry. Bam. See it?
Yeah.
All right. Work on those 5. I'm gonna stop the recording while you're working on it. But work on these 5, and then we'll move on up. I think it's 10 total. And then we'll go back over and I'll ask you, what did you get? What do you think? And we can make sure we got it. You can use them, to help you study. So I'm pausing recording now. This is questions 5 through 10. Work on these. And I'll pause again and we'll go over them together. All right, number 1, we said treat hypoxemia, decrease the work of the heart, decrease the work of the breathing, okay? Number 2, oxygen toxicity. Oxygen toxicity. Number 3, Ms. Scott, what is oxygen-induced hypoventilation?
I put that's normally for COPD patients.
Okay.
And basically hypoxia is knocked out.
Okay. Breathe slower, right?
Yeah.
Good. Okay, so that when you give too much oxygen, you knock out the patient's hypoxic drive if they are a chronic hypercarbic patient. Not everybody, just your chronic hypercarbic patient or your COPD. Okay. Number 4, Kayla, list the 3 indications for low flow devices.
A patient with a tidal volume of 300 to 700 milliliters. Respiratory rate low. Huh?
I think I was just saying, go ahead.
Respiratory rate lower than 25 breaths per minute and consistent regular vent pattern.
Good. Good. Number 5, who else we got going on? Mr. Clay. Number 5, what is absorption atelectasis?
It's when the nitrogen in the alveoli is depleted and it collapses.
Good. So what are the two things that are necessary for absorption atelectasis? Has to be there. High FiO2 greater than like 70%, and what? The two things, Mr. Clay, the two things that are necessary for absorption atelectasis to happen. You have to have high FiO2s, that's like greater than 70%, and obstruction. Got to have both. Got to have high FiO2s and obstruction, and that causes a depletion of the nitrogen, and it's washed out, and the alveoli falls below critical volume and collapses. Okay, so that has to be both of those there. You might have a multiple say absorption atelectasis is all of these except. Make sure you have, it has to say high FiO2 and obstruction. If it just says just because it's high FiO2, that ain't enough. If they don't say obstruction, that's not right. It's got to be both. Okay, number 6. Ms. Thomas, number 6. In a low flow system, when tidal volume increases, what happens to the FiO2?
It decreases.
It decreases. The more volume you have, the less it's going to make the FiO2 go down. Just like the fart in the car, right? If you let the window down, you get more volume in, and that makes the percentage of the smell go down. Okay? If you let the window up, you have less volume in the car, less flow, makes the percentage of the smell go back up. Okay? All right. Number 7, Miss Rose, what type of low flow device has a one-way valve between the bag and the mask? Not partial. Non-rebreather. The non-rebreather has a one-way valve between the mask and the bag so that you can't rebreathe your own gas. So when you exhale, it goes out the side only, not into the bag. A partial rebreather doesn't have a valve, and when you exhale, some of it goes into the bag. The first 1/3 of your breath goes into the bag, and then when you inhale, the first 1/3 of your inhale will be what you exhale, your own breath. That's why it's a partial rebreather. All right, Ms. Cummings, what type of low flow, in a partial rebreather and a non-rebreather, the flow is set to what liter flow and why? 8 to 10. Yes, 8 to 10 to prevent CO2 accumulation. Okay, to prevent CO2. All right, you don't want, because it ain't, there's really no CO2 there, but if you don't have enough flow, it will start to build up.
Yeah,
All right.
I got this one.
Okay. Okay. Number 9, Joshua, how often do you change a nasal catheter?
Did we say that was every day?
I think it was was it 8 hours? 8 hours, every 8 hours. And you must rotate the what? The nares. Good. Rotate the nares. But we don't, like I said, you'll never see this in the field. And finally, number 10, Ms. Scott, what is the reason the flow rate must be greater than 5 liters per minute in a simple mask?
To prevent CO2 buildup.
Good. Prevent CO2 buildup. Now go back at number 8. Not only will it need to be 8 to 10 liters to, because that's what it is, and to prevent CO2 to build up in the mask, but also to keep the bag inflated. Okay, that bag needs to be inflated, because if it deflates when they inspire, you're supposed to do what? Turn up the flow. Turn up the flow. I don't care if they already on 10. Okay, if they already on 10 and it's collapsing, you need to increase it. And if that's constantly doing it, then now we need to switch over to what kind of system? High flow, because non-rebreather is still low flow system, right? So if you got it on 10, 12, 13 liters and it's still collapsing, he's sucking that hard, it's time to go to a high flow system. Okay, now it's time to go to a high flow system. All right, so let's answers right here. I'm just gonna go through them like this, and then you can go back and pause it and do whatever you need to do. All right, let's look at another one. All right, medical gas therapy, another quiz. Let's look at this. Let me share my screen to this one. Uh-oh. Nice chat. Hold on. Sometimes don't show me the chat. It's not showing me the chat. Whoever chatting, I can't see it. It won't pop up. I'm selecting it, but it won't. You got to tell me out loud or email me if it's personal.
I'm just saying I'm stepping away for a minute.
Oh, okay, no problem. We do new share. All right, let's look at this one. This one, there's a little bit of blast from the past in here. Got to keep those in there at all times. 9 is the last one on this one. All right, let's go over them. Number 1, what is the normal interpleural pressure at resting expiratory level? Should be -5 centimeters of water. -5 centimeters of water. Number 2. Write the formula and definition for compliance. Compliance is change in volume over change in pressure. Compliance is the change in volume divided by the change in pressure. Number 3, write the name of the 4 lung volumes. Tidal volume, IRV, ERV, and RV. Okay? Number 4, Ms. Rose, describe one of those in English. Residual volume and, let me describe it in English.
The residual volume is what's left over after a normal exhalation.
Not normal. What's left over after a normal exhalation is FRC, but what's left after a forced exhalation is reserve volume. So RV is the amount of volume left in the lungs after a forced exhalation, right? That's what you can't get to. You push, 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 but you still can't get to it, okay? Ms. Cummings, tell me another one.
Another volume.
Yes.
I guess ERV.
ERV, expiratory reserve volume. Explain that in English.
It's what you can do after the exhalation, or normal exhalation.
Good, good.
Press out more.
Good. So the amount of gas you can exhale after a normal exhalation. Good. That's my ERV. All right. Ms. Scott, can you tell me one?
I put the tidal volume.
Tidal
Just
volume?
Yes, normal air inhale and exhale.
Good. Normal air inhaled and exhaled is tidal volume. And Mr. Clay, can you tell me the last one?
You want residual volume or inspiratory reserve volume?
Inspiratory reserve volume.
That is the amount of air you can inhale after a normal inspiration.
Good, good. All right. That's all 4 of those. All right, number 5. Let's see. Oh, number 5. Write the names of the 4 lung capacities. So, Ms. Renfro, can you give me one of the lung capacities?
Vital capacity.
Vital capacity, and explain that one. So we go and knock 5 and 6 out.
Everything we can do in and out.
Good. Everything that the maximum amount of air you can inhale and the maximum amount of air you can exhale. Good. Miss Thomas, can you tell me another capacity?
The inspiratory capacity,
Good. What is that?
the maximum inhalation following quiet exhalation.
Good. Good. Maximum inspiration following a quiet exhalation. So that would be tidal volume plus IRV gives me inspiratory capacity. Hi, Ms. Cummings, can you give me another one?
Total lung capacity.
Total lung capacity.
And it's everything. The IRV, the tidal volume, the ERV, and the respiratory.
Residual volume. Good. Everything in your lungs, everything, all of the capacities in lungs, all of the volumes. All right, and is that all of them? No, one more, Miss Rose.
Inspiratory capacity.
No, we did that one. FRC is the only one left. So there you go. Tell me about that one. Is what you said the first time.
The air is well.
After what?
A normal, exhalation.
That's it. The amount of air in the lungs after a normal exhalation is your FRC. FRC, guys, is very, very important. That's your functional residual capacity, and FRC is directly related to what? Compliance. It's directly related to compliance. That means if the FRC compliance go up, the FRC goes up. If compliance goes down, FRC goes down. FRC is indirectly related to what? No, just like compliance is indirectly related to, think about the rubber band. Elastance. Elastance. If the elastance is high, you have a low compliance. If the elastance is low, you have a high compliance. Okay. All right. So make sure you're able to add those three together, right? If high FRC and high FRC and low elastance are, if that's true, then, and if low elastance and high compliance, right, is true, then high compliance and high FRC must be true. See, you got to be able to relate those three together. All right. So that was 5 and 6. Don't forget about the normal values for the 4 volumes of capacities. So, Miss Taylor, inspiratory capacity is how much? She might have to step away. Miss Scott, inspiratory capacity is how much?
I think 2.4.
No, I see what? 3.6. So 3.6 liters for inspiratory capacity. Mr. Clay, what about total lung capacity? How much is that?
I do not remember right now. Hang on one second. What was it again? Total lung capacity? 6 liters.
Yeah, 6 liters. Good. 6 liters. Okay. Let's see here. Caleb, what about FRC?
2.4.
2.4. Good. Miss Rose, what about RV? 1.2. Miss Scott, what about vital capacity?
0.5. I
Nah.
mean 5.
No, vital capacity is what? 4.8? I think it's 4.8.
I'm sorry, I'm thinking of tidal volume.
That's tidal volume. Good. That would be tidal volume. All right. All right. And Miss Cummings, what about
ERV and RV is the same thing. 1.6.
okay, what about IRV?
3.1.
3.1. Okay. All right, let's go on. Number 8, according to Egan's, what is the normal range for respiratory rate in adults? Anybody? 12 to 20. All right. And then number 9, list the 11 components of the tracheal bronchial tree. Just give me from the top to the bottom. You don't have to tell me a generation. Starting with the trachea, then Miss Rose, you go into the what? Bronchus, and then Miss Cummings, you go into the bronchi and segmental bronchi, right? Miss Scott, then you go into the
Bronchioles.
And Miss Renfro, then what?
I don't know.
Terminal bronchioles. And then Mr. Clay, you go in after the terminal bronchioles, go into the
Respiratory bronchioles.
Miss Rose, which is the land of the parenchyma, and that's where the alveoli are found, right? Good. That wasn't hard. All right, let's look here.
Look, I'm surprised. I thought it was gonna be good.
All right, so the last, you doing what now? Yeah, that's what I want you to do. Try to do that way. All right, so now I'm going to ask a couple of questions. I have to stop recording, but I'm going to ask just a couple of alternate exam questions, okay? But I have to stop recording, all right, because of that exam, all right? Let's see here, new share. I didn't get that. Do 6 and 7. Y'all work on 6 and 7. Work on 6 and 7. It's a sample question that could possibly be on a test. Won't be these, but these were on a test. And so when you come in tomorrow, first thing we'll do is we'll have the stuff out on the table, let you kind of play with it a little bit, hook up a few things, and then I'll check you off on the high and low flow systems, and then we'll clear our desk and take the test, and you'll be done. We will be in the lab tomorrow. All right, number 6. Joshua, to assure a stable FiO2 under varying patient demands, what must an O2 delivery system be able to do?
I'd kind of guess on this one. I think it's D, delta, to be able to deliver O2 concentration from 21% to 100%.
Okay, no. Oxygenation, remember, we said that oxygenation might not necessarily be the problem. It may be a flow problem. We're looking for the flow problem, because if it's very, yeah, B, good, B. Provide all the gas needs by the patient during inspiration. You got to be able to meet the patient's what? Demand. See? Got to be able to meet the patient's demand. Okay? You don't know anything about peak flows. The peak flow is what you exhale. That, remember, when I blow out real fast, that's a peak flow. We're not worried about that. The system that we set up, whether it's the aerosol trach collar, aerosol T-piece, right? The total flow must be able to meet all of the patient's what? Demands. So that was best choice would be B. Provide all the gas needed by the patient during inspiration. What he needs, you got to give him what he needs. It might be, Joshua, some oxygen. It might not. Like we said, when you're short of breath in the car, you let the window down. But the FiO2 in the car and outside is the same. It's the same oxygenation, but it's giving you more flow. Okay. Sometimes they need more flow. They're in the hospital and they want somebody. I can't breathe. Give me the fan. Turn the fan on, right? It's blowing the same oxygen around, but it's giving them more flow. Okay, Ms. Cummings. Number 7, a physician orders oxygen for a patient with documented hypercapnia and hypoxemia. What is the most appropriate action in this case?
I think it's B.
In this choice, I would say B. Administer O2 to achieve a PaO2 of 60 to 70 millimeters of mercury. 50 to 60 is kind of too low, okay? But 60 to 70 is mildly hypoxic, right? That's what we want. Good. That's what we want, because he's 47. That's too low, okay? We need to give him some O2, but we don't give him too much, right? And so we want his PaO2 to be around 60 to 70. That would be the best choice. Not the highest possible, right? Or not to give it to him at all, okay? And 50 to 60 will be a little low. Okay? That's a little too low, okay?
So you want to get to where they're mildly hypoxemic?
Yes, you want to be mildly hypoxemic. Mildly, okay? It might be a little more than mild, but it just depends. There's no specific exact PL2 you want them to be at, because everybody's a little different. Okay, everybody's a little different, but 60 to 70 would be your best choice in those answers.
So I have a question.
Yes.
So if COPD patients are there and they you want them to be mild hypoglycemia or positive, but say for instance you get them to about 70 to 80, and it seems like it's slowing them down, and they CO2 is good enough. How would you go about fixing it?
Well, if they come in and you put them at 60 or 70, it's not going to seem like it's not going to affect that fast. Remember, nothing's going to affect in less than 24 hours. It's going to be 24 hours before you see effects of O2 induced hypoventilation. Okay, it's going to be about 24 hours before that really starts to take effect. So if they're going down while you give them out, it's something else causing the problem. Something else going on. Okay, something else is going on. All right, let's look at two more. Look at 9 and 10. Well, don't worry about 9 because we didn't talk about. We're going to talk about the bubble humidifier when we get to humidifiers. So let's not look at that one. No, let's look at trying to make sure it's something we can do. Look at 11 and 12. (11 and 12). 11 says a doctor places a patient in respiratory failure. He already in respiratory failure, and we already said that respiratory failure means that they couldn't get off the CO2 for whatever reason. If CO2 is so high that they can't breathe and pass out. He puts a patient in respiratory failure on 100%, and to avoid the hazards of O2 toxicity, you recommend that every effort be made to reduce this FiO2 within which time frame? And then number 12 says, what is the key functional difference between disposable partial rebreather and the non-rebreather mask? The key functional difference between the two. All right, Miss Scott, number 11. A doctor places a patient in respiratory. He came in an ER. He's respiratory failure. We put him on 100% to get him up, get him right. But to avoid the hazards of oxygen toxicity, you recommend that every effort be made to reduce this FiO2 in what time frame, Miss Scott?
I put 8.
Not 8 hours. It should be 24 hours. 24 hours. Remember, Shapiro said that, or the general guidelines of O2 is that no O2 or 100% O2 has not caused any problems if given within 24 hours, okay? As long as you take it off of them in 24 hours, 100% is okay, because sometimes you have to give 100%. Don't be scared to give 100%. As long as you don't give it for over 24 hours, that's when you start getting into problems. Okay, if it's over 50% from 24 hours, that's when you start getting into toxicity, right? Or if it's 100% and you have an obstruction, right, then you get an absorption atelectasis, right? Stuff like that. So 100% less than 24 hours is always okay. But 24 hours, we need to start getting this oxygen down, okay? We don't want to have it on there for greater than 24. Number 12, Kayla, what is the key difference between disposable partial rebreather and the non-rebreather mask?
D.
D, the non-rebreather has a one-way valve between the mask and the mask. Exactly. Good. All right. 13 and 14 will be Ms. Cummings and who else on there? I'm getting everybody. Ms. Cummings and Ms. Rose. Y'all do these two. Miss Rose will do 13 and Miss Cummins will do 14. But everybody work on them, see if you get the same answer they get. Okay. You go ahead and get logged in, and I'll let you go ahead and be taking your test since you got 2 of them to take. Y'all still see the screen, the question? Y'all still see the question? Okay, because I moved off. Okay. Okay, you can go ahead and take A first. A is open for you now. Okay. All right, Miss Rose. Did I say you was 13? Okay, Miss Rose. A patient with chronic hypercarbia placed on FiO2 of 60% becomes lethargic. What is the possible cause of this response? C. That's it. O2 induced hypoventilation. Didn't say how long he was on, just say he's becoming lethargic. So evidently he's on for a while and he's becoming lethargic. So that's O2 induced hypoventilation. Good. Ms. Cummins, number 14. Retinopathy of prematurity is potentially serious management problem, mainly in the care of who? A. Premature low birth babies. It's babies. Retinopathy of prematurity. Okay, that's your babies or your low birth weight infants. Good. All right. Joshua Clay 16 and Miss Scott 17. But everybody work them. See what you get.
A and C.
Okay. It is C, 80 millimeters of mercury. 16 is C, 80 millimeters of mercury. Got to keep the baby's PaO2 below 80, 80 or lower. Okay. If not, it starts to cause vasoconstriction in the retina, which will cause necrosis of those blood vessels, and then those blood vessels, new ones will be made automatically. And when that happens, they hemorrhage easily because they're freshly made. They hemorrhage, and the blood will scar the retina, causing the blindness. Okay. Number 17. Who I say 17 was? Miss Scott. Yeah, Miss Scott. Number 17.
I was trying to figure this one out. Wasn't I think A.
1 and 2. It does do that, but it does it all. Okay, the best choice would be all of those. Decrease the symptoms caused by chronic hypoxemia, because if you are hypoxic, you're going to have symptoms. It's going to treat the hypoxemia, and it's going to decrease the workload of the heart and the lungs. So it's all of those. All of those. All right, here's a little bit of math. All right, so well, too bad, Miss Cummins, you already had one. Miss Kayla and Miss Thomas, 18 and 19. And y'all all could be looking at 20. Even though you don't see the results, you can be looking at 20 as well. You should know that without looking.
What is the FiO2 on number 18? Oh,
35.
we can move this along.
What you mean you move it down?
Nah, okay, this what. Okay, I didn't know that. Yeah.
Oh.
I'm like, huh?
All right. Who I say this was? 18.
Hey.
All right. So a physician has, now let's listen to the question. A physician has requested delivery of a controlled moderate concentration of O2. He wants a controlled, right? He wants a controlled delivery, 35% to a tracheized patient. So somebody has a trachea. So which of the following systems is best and simplest way to achieve this goal?
D.
Say it again. Which one you say?
D as in dog.
O2 catheter? No.
I got you.
Air and O2 blending system with T-tube? I would have went with A. Air entrainment nebulizer with a T-tube. That's the aerosol trach collar. Aerosol T-tube, aerosol trach collar, right? The air entrainment nebulizer. That when you hear that word air entrainment, that's the Venturi. That's when you're gonna do 35%. Right now, the other one says an air and O2 blending system with a T-tube. So either one I would have took. Okay, I would have took.
I went with C though because it said control.
Yeah.
So I thought entrainment they gotta let. Yeah.
When you entraining it, you are controlling it because you turn it into the FO2 you want.
But I thought well, my thought process was saying like there was a lower and I thought you wanted like the absolute.
Yeah, that's the air entrainment device is a high flow system. That's the
What
Venturi.
was that you changed out in the video that you showed us?
The what?
What was that you changed out in the video that you showed us?
You changed it out. What you talking about?
You changed something out in the video.
Oh, that was just for the tandem. That was the green one for the tandem. The best one you need to know, guys, is when they want a controlled FiO2, you got to use a high flow system. And the high flow system that you have learned is your aerosol whatever, okay? If he has a trach collar, then we know T-tube and T-piece or trach collar can work for a trach patient. But air entrainment device, air entrainment, that means accurate, okay? Air entrainment means the Venturi. It's going to suck in air to bleed the oxygen down to what you want, specific FiO2, okay? That's the air entrainment device. Now, if you would have said air and O2 blending system, because a blender can give you a precise FiO2 too. So that was kind of not, that wasn't clear of what they were saying on that one. So I would have taken A or C with that one, okay? Because I can understand your rationale for C, but A for sure, okay? The air entrainment device, okay? Air entrainment nebulizer with the T tube. Number 19, who's 19?
Would it be B?
Okay, no. Whenever you give a heliox or any kind of gas mixture, always give it with a non-rebreather. Because if we want them to have that mixture, we got to be specific as possible. I don't want you breathing your own air. I don't want you on an aerosol mask with the big holes on the side, right? I need you to get just this 30 and this 70. So anytime you give a mixture, heliox or any other kind of mixture of gases, always use a non-rebreather mask, okay? Because that's going to give us the best percentages, right? Because whenever you get a non-rebreather, you breathe in 100% of the source gas, right? So if it's hooked up to the oxygen tank, you're going to get 100% oxygen. If it's hooked up to a heliox tank, you're going to get 100% of whatever that mixture is, okay? So always remember, whenever you have a mixture of gases, always use a non-rebreather. Okay, always use a non-rebreather. Oh, what y'all get for 27? I mean, number 20. 40%? D. That's using the rule of what? 4. Using the rule of 4s on a nasal cannula. It's not guaranteed, but we can estimate the FiO2 because that's a low flow device. We can't guarantee the FiO2, but we can guesstimate if they are on a 5 liters nasal cannula, they're probably going to be getting about 40%. All right, a couple more, then we're going to be done.
Mr. McCarthy, on that last question, why you said that's 40%?
Because of the rule of 4s. Remember, look at your lecture about the rule of 4s. Whenever they're on nasal cannula, you go by the rule of 4s. 1 liter would be considered 24% because room air is 20.95, really 21, but they go by the 20.95. So 1 liter would add 4 more percent. So 1 liter would be 24%, 2 liters would be 28%, 3 liters would be 32%, 4 liters would be what? 36%, and 5 liters would be 40%. Okay? The rule of 4s. All right. Everybody, look at number. Look at number 3. Everybody look at number 3, and then we're going to be done. A doctor orders delivery of 35% O2. Now, he's telling you how much he wants. He wants, or she wants, 35% FiO2 with aerosol. Okay, she wants with aerosol to a patient with an intact upper airway. He has an intact upper airway. Which of the following devices could I use to meet this goal? You got to be an aerosol now. It's got to be the aerosol, and it's got to be exactly 35%. And they have an intact upper airway, which means they don't have an artificial airway. So it's a couple of those I could use. All right. Ms. Scott, what you think about this one, number 3?
Yeah, I'm lost on this one. I'm thinking the O2 mass, but I can't see about the other answers.
Okay. What about you, Mr. Clay?
I was gonna say nebulizer with the T-tube and maybe the nebulizer with the aerosol mask.
What you think, Miss Scott? I mean, Miss Rose. You said B as in boy, D as in dog. Okay. What you think, Miss Cummings?
I think A.
Answer is A. This is a 35% aerosol device, and the patient has an intact upper airway. So I wouldn't use a T-tube because he has an intact upper airway. His face is fine, okay? I mean, his airway is fine. He doesn't have a trach and he doesn't have an ET tube, all right? And so the ones I could use, not the simple O2 mask, because that's a low flow device. That doesn't go with the nebulizer, right? So it couldn't be one. It's the nebulizer face tent, right? So the aerosol face tent would be okay, or the aerosol face mask, right? Aerosol mask, nebulizer with the aerosol mask. So both of those will go on somebody who has a regular face, like me and you, right? We're regular. Put the aerosol face mask on, or the aerosol face tent, right? Either one of them would be for the person with an intact upper airway. Couldn't use a T-tube or the Briggs adapter because that's for somebody who has either an ET tube or a tracheostomy. So couldn't use that. A simple O2 mask is a low flow device. I can't give 35% with that, period, because it's a low flow device and it doesn't go with nebulizer anyway. So you can take one out of the equation immediately. So that would take out B, right? And then the T-tube I can't use because they have an intact upper airway. So I can take 3 out. So 1 and 3 can go. So that gets rid of D, that gets rid of C, and that gets rid of B. Only thing left is A. Okay? Don't forget to use process of elimination if you can. The doctor ordered 35%. In your mind, you automatically say, okay, that's a high flow device. I can't give 35. I can't give an accurate FO2 with a low flow device. If she said I want 35, you got to give 35, right? And so the simple O2 mask, what type of device is that? Low flow. So that's out, right? And they have an intact upper airway, so the T-tube is out, right? So that only leaves face tent and aerosol mask. Okay? So that is a sample test. Okay? And y'all did fairly well with that. All right? Did fairly well with that. And the test that you have tomorrow probably a little easier than that. It's not that bad. So make sure you look at that. Look at this lecture. Look at yesterday's lecture. Do your reading. All right? That's how you're going to get ahead of the game on this. Okay? We are done with the lecture. Tomorrow, I've already put the homework in for tonight. And tomorrow when you come in, we're going to come in and bring your lab book. Make sure you're dressed out and bring that lab pages that are in the syllabus. All right? Make sure you complete that part of the lab book that's in the syllabus. And I'll let you play around with it, hook them up, disassemble it, before I check you out. I'm not going to say, okay, what is this? What is this? As soon as you come in. But I will give minimal instruction on that because you should have been watching the videos and watching the lab videos that are in the module. Okay? So look at those, study, come in, we'll play with it a little bit. I'll check you off. And then we'll come back to the classroom and take the exam and you can go home. Okay? We'll start the next lesson after that the next day. All right. See you later.